Hello and welcome to today's ICU Liberation webcast on interprofessional team coaching in the ICU, results session 2. My name is Diane Byram and I will be moderating today's webinar. I am joined by Vishaka Kumar, Manager of Quality with SCCM. We will focus our shared learning today on interprofessional team coaching. A recording of today's presentation will be available at www.iculiberation.org within 3 business days. Please take advantage of this resource to further educate your colleagues. A few housekeeping items before we get started. There will be a question and answer session at the end of our call. If you have a contribution or a question, type it into the question box along with your hospital's name. Questions will be addressed at the end of the session. Please do not be shy. We are all here to learn and very much want to talk during this session. Continuing education for this activity will be eligible for CE/CME credit. Information on how to claim credit will be available at the end of the webinar. So it is my pleasure to introduce our presenters for today's webcast. Mary Ann Barnes-Daly, Sutter Health Clinical Improvement Specialist, is part of the ICU Liberation Steering Committee and West Coast Regional Faculty. Mary Ann Barnes-Daly co-authored the book chapter, Using an Interprofessional Team Approach to Implement Evidence-Based Practice in SCCM publication on the ICU Liberation released in 2015. Dorothy Lindgren is with Sutter Health as a team development coach. Dorothy created the first interprofessional team curriculum, which is now being used system-wide to support the implementation of the ICU Liberation to implement the ABCDEF Bundle. We will now see the disclosures from the faculty as noted. And now I will turn that presentation over to Mary Ann and Dorothy.
Good morning, everyone. This is Mary Ann Barnes-Daly. Thank you all for joining us. And this is my colleague, Dorothy Lindgren. Sorry, we're having a little delay with the slides.
Go back to agenda.
I'm trying to.
Yeah. So to start out, we just want to review what our agenda is today. And many of you were on our call last time and did a test of change experiment. And we're going to go over those experiments today and specifically dive a little deeper into 4 of them and see what you did in partnership with others. Then we're going to talk about what inevitably happens with change, which is that resistance happens, conflict, and it becomes sometimes difficult to influence people to make the changes needed to implement this bundle. So we'll be talking about the key ability of cooperation to do that. And then lastly, we'll look at what needs to be done, what processes need to be changed or integrated to successfully implement the bundle. So our purpose then is to continue to collaborate with each other, and collaboration often looks like collaborative decision making with all of the roles that you see there on the right. You'll remember we talked about that in more depth last time. And you'll also remember that in order to work as a team interprofessionally, 3 key abilities are necessary. Again, partnership that you tried out as you did your test of change experiments, coordination, which is that process integration piece. How do we integrate our processes together to achieve our goals? And then cooperation. Cooperation often just looks like, how do I need to listen better and contribute or confront sometimes other people's resistance? You good?
Just didn't go.
Oh. We're having slide advancing issues here.
So SCCM partners, perhaps you'll need to take back control and advance when we ask, because I'm not able to advance at this point.
Thank you so much.
Thank you.
So you remember this. This was how we left our session last time, which is let's try some things out. Let's do a test of change experiment. So what we want to do is first just commend all of you. I'd like to go back to that list. Thank you. Commend all of you who did a test of change experiment. There was actually all of these plus 4 others that we're going to look at in more detail. You'll notice a lot of you did test of change experiments around rounding. So you'll see that. A lot of you did test of change experiments, including patient and family. You'll see those words coming out. Really excellent work. And then some of you looked at other things, such as coming up with information sheets and trying the quiet time, collaboration around having quiet time. So loved reading all the work you started out, and great work there.
And to add on to Dorothy's comments, I really like to see those of you doing tests of change that include the family, because as we realized with our cartoon that we showed earlier, the patient and their family are equal and integral parts of our team. So for those of you that focused on that, creating a real team, that is a great focus of teamwork for this work. So we'll again congratulate you on that. We would like to have some of our participants share their test of change experiments. We would like to begin with Bayfront Health from St. Petersburg, who focused on celebrating patient mobility.
Hi, this is Madeline from Bayfront. What we did over here at Bayfront was, let me give you a little bit of the background. Earlier this year, and in fact last year, before we got involved with the ICU Liberation Project, almost all of my nurses were very hesitant to ambulate our patients when they are on the vent. They would just turn patients left and right and center, but they really were hesitant to get them out of bed. With the ICU Liberation Project, we started pushing for increased mobilization of these patients. And when we started getting these patients out of bed, we made a big celebration, gave them a lot of recognition when they started getting patients marching at the side of the bed, sitting at the bedside, and we were giving nurses, our staff nurses, the super nurse ID badge holders, and talking to them and letting the physicians know just what we did, and giving them just the big warm fuzzies that made them be recognized by all the other disciplines. When I get to the
Thank you. So what did you see? First of all, tell us how your team worked together to create this test, and what was the one main thing that you saw as a result?
Our team was comprised of the different disciplines, the ICU nurses, the physical therapist, the respiratory therapist. Pharmacy was very much involved. Our trauma physician and the intensivist were involved. And we looked at which ones were the good candidates for ambulation. We look at our orders and make sure that the orders that we had lent to increasing mobilization of these patients. We'll look at the medications that we had, making sure that we were weaning our patients as early as possible off the sedation.
Thank you very much.
Multidisciplinary.
Yeah, that was one of the things that really stood out for us. Thank you so much, by the way, for sharing that. One of the things that really stood out for us that Marion was hinting at was how you really had to involve so many of the other disciplines to do this. And what I really liked about your test of change example that you sent in is it really was a small test of change. It really got to, let's mobilize one patient and let's celebrate that. So we included the word celebration here. From what from what I read, you really did a great job on that one patient celebration and saw some real results afterwards of, oh, if we celebrate this one, we're going to get continued results in the future. Did I capture that correctly?
Yeah, you sure did, and that's what we did. We made a big to-do, so to speak, of the first one that we ambulated on the vent, and the second, the night shift staff basically wanted to do the same thing because we went through the big celebration of the first vented patient that we had.
Yeah, great job, great job.
Great, thank you very much for presenting and sharing your work with our teams. The next team we would like to highlight is Kettering Medical Center, who did a test of change involving bolus first fentanyl guidelines. Kettering, please go ahead.
Hi, this is Delane Adrian from Kettering Hospital. Our test of change was based around sedation practices, specifically trying to improve and optimize how we were administering fentanyl. So we worked to revise our current fentanyl order set. Currently it doesn't really provide any guidance and has a max rate of around 300 mics per hour, and we were finding that a lot of staff had a tendency to turn rates up versus treating the acute pain. So we started with revising that order set to where it would meet the needs of the pharmacy staff, the physicians, and nurses. And then we started with one patient and kind of worked out the kinks from there, decided what would work, what we were missing in the language. So we've been kind of recycling that pretty quickly, getting that back out to the staff. Really the main thing that we learned was staff was very receptive to improve that communication so that everybody was standardizing their practice for sedation. And they also felt like it kept them from resisting the urge to always turn the drip up.
Very nice. Really great work. And you know, the pain, agitation, and delirium guidelines obviously recommend bolus approach for the reasons that you stated, not only to get patients to reach their pain goal, but also for breakthrough pain. And if we stop pain medication as part of the SAT, it's really important to resume it with boluses for the reasons I just mentioned. So this has a really widespread effect to bring evidence-based practice to your unit. So great work on that. Dorothy?
Yeah, again, yeah, great work. I appreciated how you got the initial idea but didn't hesitate right away to bringing that back to your team. And again, love the word recycling that you use. Trying something small and then going back and trying it again and bringing it back around, getting that kind of buy-in and starting to move into getting more and more support. Yeah, great work.
Thank you, Delane.
Thank you.
Our next team that we'd like to highlight, as soon as my slide advances, is South County Hospital, who did a test of change around mobilization of intubated patients. Go ahead, South County.
Hi, this is Siobhan from South County. We did a test of change on mobilizing the intubated patient primarily because we needed to collaborate better as an interprofessional team. Nursing has been educated on initiating an early mobility protocol, but we really were relying primarily on physical therapy to get these patients out of bed. So we decided that it would be best if we kind of worked together, did some in-servicing, got everybody on the same page, and removed some of the level of fear. We had to do some education because a lot of the physical therapists felt that it was, quote, unsafe or uncomfortable for these patients to be getting up to the edge of the bed. So we provided some in-servicing on that, and then we did, we had one specific patient that we worked with on a daily basis, and we were able to increase the level of mobility over a few days, working, you know, really collaborating together with physical therapy and nursing and the physician, and having everybody there and everybody see how smoothly things can go, and that it really does actually really improve the outcome for the patient.
Thank you, Siobhan.
You know, I think
okay. Sorry, go ahead.
No, go ahead. I think it went well. You know, it kind of, it took some of the fear away, and that was our goal.
Right. Excellent work. What I really liked about yours, your test of change, was it was kind of dual purpose. So you had something that you wanted to improve, and so you used teamwork, but you wanted to improve teamwork, so you chose mobility. And I think, again, that was a win-win. And also, again, your rapid recycling and choosing a small test, using one patient and increasing the mobility each day to prove to the team that it can happen. And again, our national expert, Heidi Engel from University of San Francisco, says, particularly with early mobility, seeing is believing. So those of you that are using that tenet to improve and have your mobility be more widespread, that's really excellent work.
Thank you.
Yeah, that's great.
Okay, thank you so much, Siobhan. Our next test of change is from Wooster Community Hospital, introducing the staff to families. Is Wooster on the line?
Yes. Hi, this is Karen Steiner, the ICU director, and I'm joined by Joanne Pano, our ICU clinical nurse specialist. Our test of change was in regard to staff introduction to families, and our goal was to increase patient, staff, and family engagement and satisfaction with the whole ICU process of care. And so the test was actually not just the staff introducing themselves, but we were focused on that a great deal because we found as the different members of the different disciplines would be in rounds, sometimes people would forget to introduce themselves or they wouldn't speak up enough. So we really focused on having the team members purposefully approach the bedside, make eye contact with the patient, and introduce themselves in a level of voice that the patient and the family can hear. And then more importantly, the primary nurse then would introduce the family members so that the team knew who was in the room, and the goal was, the hope was to get the family then more engaged because they were introduced and then they felt like they were more part of the team.
Right, and they were more able to ask questions and ask for clarifications around the care that their loved one was receiving. And
excellent.
So,
did you have any experience with this process unduly extending the time you needed to spend with an individual patient, or did things run smoothly?
I think things ran smoothly because I definitely noticed a big difference with the questions would still be asked by the family members, but I think they would just then be asked later on outside of rounds, which, you know, that's the whole point of the rounds with the family, is to ask in front of the whole team. I don't really think it increased the amount of time.
no, and I think it actually increased the level of satisfaction among the family members and patients and with the staff, because I think there was a personal connection then that was made, and it was, so you saw people relax a little more, you saw people being able to ask those questions and even at times laugh or make a joke or just, I think, overall be a little bit more interactive with the team, but it did not increase the length of time that rounds took.
Thank you for sharing that. Thank you both very much. It's also something that we see, and often sometimes nurses and physicians specifically are really reticent to include family in rounds because they think it's going to extend the time and have too many questions. And when it finally happens, the physicians actually tell me it decreases the time I spend with patients because I don't have to go back so often afterwards. I don't get pages later on in the day. And so it's really great that you tried this, and it dispels some of those myths for both your team and others on the phone. We also hear some challenges, and you can see that Wooster is a community hospital. We hear challenges from large academic centers that have, you know, large teams and sometimes multiple teams rounding through a unit on a particular day. And so that does create a little extra consideration around how to include the family and still be, you know, expeditious. However, I'm really glad to hear the results that you've had. Those are results we're seeing from across the country, and I think your dual purpose of improving bundle compliance with the F, but also improving patient and family satisfaction is a really, really worthy goal.
And I just want to say thank you overall to all four of you. examples you gave of collaboration are so much more powerful than us saying you really need everyone to work together on this bundle. It doesn't happen. It doesn't happen with one profession, and your examples, and it doesn't happen without the patient and family, as you just pointed out. Your examples really, I think, pull that out for all of us. So, for the 4 of you and for all of you who did your test of change, you know, just really want to commend you for that. And also just want to add that a test of change is just the start, and the next step is to do another test, to, you know, get that circle wider, to bring in more people, to try something else out, either try the next step in this current test or try another test. We find that our interprofessional teams around this bundle just continuously do tests. They meet every week or 2 weeks, and they just continuously reporting on, I tried this test of change, I'm trying this next, this is my result. Just encourage you to continue with that. So I think that the key ability of partnership has just been demonstrated beautifully, and want to move on now to cooperation. What does it take to get cooperation? This material around contrasting statements, we think really hits at how do I address conflict or resistance when I have that with someone else, because it, like I said, is pretty much inevitable. Contrasting statements really lets the other person know that you also care about what they care about, but you can still get your point across. It also diffuses the fear and defensiveness. It's tough to change, and it's tough to have someone, especially outside of my profession, sometimes give me advice or tell me what I need to do. So you can diffuse that early with contrasting statements, and also get some tough messages across to the other person that maybe need a little bit more thought and softening before you just come out and say something. So yeah, go ahead. Oh, I guess go ahead. Yeah, to the next one. So what is a contrasting statement? So a contrasting statement is structured very specifically in 2 ways. So the first thing you say is what you don't want for the other person, and the second thing you say is what you do want. So it's important when you're saying what you don't want for the other person that you're not saying what you don't want them to feel, because the minute you start talking about what you don't want someone to feel, that just increases their defensiveness, because we all are going to feel what we're going to feel. So what you want to say is what you don't want them to struggle with, what you don't want them to have to think or struggle with, followed by what you don't want. So that sequence there is critical. So it's first what you don't want for the other person, and then what you do want. The example is on the next slide.
Sorry again, we're having a bit of delay with our slide advancing. There we go.
So here's an example. So the RN isn't documenting their RASS and CAM-ICU assignments. This happens with us as well. And when you ask them about it, you get a response similar to, I did it, they're fine. So the contrasting statement example then might be something like, again in your own words, what I don't want is for you to do unnecessary assessment, charting, documentation, and what I do want is for all of us to document the results of these assessments to help reduce delirium by sharing results with others and decisions about it, and decisions so that appropriate intervention and decisions can be made.
Right. And you can tell this statement is well thought out and written, and we're reading it. It's probably not realistic in a real-life clinical setting, especially when you are confronting a colleague who is not documenting when it's part of the ABCDEF bundle. So again, what's good about this statement, it says, what I don't want for you is to do unnecessary assessment and charting. Why this is necessary, though, is that we are really monitoring and measuring our patient's level of delirium so that we can intervene and mitigate whenever possible, or so we can recognize delirium and prevent it if possible, or help our patient to improve. So those sorts of things can be in your words. One of the things that we encountered when we worked with our teams across our system is that often when we had folks in the room who were part of the management, for instance, unit managers or directors or charge nurses, they often said something like, what I don't want is for you to not document. What I do want is for you to document, right? So, I mean, that's not a contrasting statement. That's like kind of reiterate. What I do want you to do is to document per policy. That's not a contrasting statement. That's enforcing policy, and that's an administrative task. That's not something that really gets to a person's reluctance to just do normal work because it's new. So these contrasting statements work much better when you use them peer-to-peer, and you don't, be the big heavy with, this is our policy, you should do it, but you actually say what you don't want is for a person to do something that doesn't make sense to them. One other thing that we encountered, just as an aside, is that this happened in real life, and the nurse said to the person that was speaking to her, this person's so nice, it's a cute little old lady, I don't want to document the fact that she's delirious because people are going to treat her differently. So you never really know why people are doing or not doing the things that you're observing. So it's also a good way, these contrasting statements, to open up a dialogue to find out exactly what the person's resistance is and then help them to move forward through that.
Yeah. So I would just reiterate again that the two key pieces of this is what I don't want for you and what I do want. Those have to be there in all of the statements in order for it to be a contrasting statement and for you to get the effectiveness of this. Marianne brings up a really good point, which is it's only an opening. So that next piece of what questions do you have can be really helpful. So these differences continue to happen. Contrasting statements help address those, but they're going to continue to happen. We want to make sure we're clear around how a team needs to address these differences. So we're going to do a poll here, and we're going to have you look at this situation. A new intensivist is rounding, or a hospitalist. The IPT recommends extubation. Everyone agrees, all the roles, but the intensivist wants to wait until the admitting physician arrives later, let's say later in the afternoon. So we're going to give you three choices. One is it's the intensivist decision, so the IPT agrees to wait. The RN tries to call the admitting physician to get their recommendation through, and then the IPT members present educate the intensivist on the process. What I'd like you to do is really think about what would happen if this happened in real life, where you're sitting, where you are. So do you want to provide them those, no, not this one, but the ability to answer the polling question there? Choose 1, 2, or 3.
Sam, can you activate the polling question?
Seems like we're having delays on some of this.
Yeah. Okay. It looks like we are missing our polling slide. So why don't we just go ahead and provide the results?
Yeah, I can go ahead and speak to that. So what we see typically is that all three of these things happen quite commonly. The first one happens where the team is in agreement, but the intensivist or hospitalist isn't quite there with them. So the team feels like they don't have any choice but to wait. So team agreement is good, and at the same time, we've got to figure out a way to get everyone who's in the rounds and part of that decision in on that decision.
Yes, and to follow on that, what we often see is we have a team that's working well together, and we have a physician lead as part of that team, an equal part of that team. And their culture modulates to where they're sharing decision-making and working together to do what's best for the patient. But when a new physician often comes in, the system kind of falls apart, the culture falls apart, and there's deference to that physician's decision. And so the new way of rounding and sharing decision-making kind of goes away. and then we go back to this expert decision-making model, and the team kind of stands back. It's really important for the team to stand together and work to make sure that everyone is on the same page.
Yep, yep. So the second one, where the RN is trying to call the admitting physician, we see this a lot, especially with the absence of processes that need to get put in place. The administrative RN really wants to make this happen. Everyone's on the same page. How can I do something? So they start calling around, takes a lot of time, and really isn't a sustainable process, which is obviously where we're headed with this interprofessional team.
Right. And we see this also in cases where one physician will say, okay to transfer out of the ICU if it's okay with this service, or okay to discontinue this drug if it's okay with infectious disease. And it really puts the nurse in the middle of trying to make things happen, and it of course causes delays. So what Dorothy's referring to is, if that is part of your culture and behaviors that certain physicians have, it would be important really to put processes and structure in place to make that not really the default, and to not put all of that coordination back on the RN to make it happen, but make sure that the team is in a position to have processes of coordination so decisions and actions can be taken at the time of rounds.
Yeah. And then the third one, the IPT members present educate this intensivist on the process that's in place. So you have a process, it gets referenced, the education happens, and the team stands with that intensivist on making this decision. Now, usually what needs to happen for number 3 to occur is not just that you need to have processes, because you do, but also some kind of contrasting statement. So you can probably think of contrasting statement for that one. Let me just say, starting out with what I don't want. So if you're talking to this intensivist, you would say, and remember, it's what you don't want for them. So what you don't want for the intensivist, what I don't want for you to think is to think we're trying to take care of this patient without your involvement or without the admitting physician's involvement. What I do want is to support you, right? I want to support you in extubating this patient so we can reduce the likelihood of delirium. So you can see where a contrasting statement, once you have all the processes in place, can really begin to bring folks on board.
Right. And remember that knowing that physicians rotate in and out of the unit, may be covering for each other, or your lead physician champion may be on vacation for a while. One of the ways to prevent this from happening, and this works really well, is to have your physician lead or physician partner in your team to speak to his or her colleagues, to say, we're doing things different now, and to set them up for success, because no one wants to come into a group of people and seem like they don't know what's going on. It often causes defensiveness out of not wanting to look bad or dumb, and then we don't see their best behavior. Another way is, if your physician champion isn't able to kind of preemptively talk to colleagues, when rounds start, it's probably a good idea to set some ground rules and say, we've been working on a new process, here's how it works, we each make recommendations, and we work together as a team to come to a decision. That sets the new person up for success and gives them some information about how the team has changed their culture and the way they function.
Mm-hmm. We're ready for that next slide. So far we've covered 2 of the key abilities. The first one is partnership, and you really covered that when you talked about how you worked with your team to do small tests of change. We covered the second key ability as well. All of a sudden I can't remember, cooperation. Of cooperation, where how do you get cooperation and how do you present things in order to get that kind of cooperation from others. And then the last piece is really often where it's the toughest, which is how do we put all this together, especially with so many roles, so many professions involved. So go ahead, and you want to give them those instructions?
Yes, so we would like you, not in the chat box, but in the question box, the place where you would ask a question at the end of the presentation. List in the question box an area of coordination that you feel is particularly important as your specific team implements the ABCDEF bundle. and we'd like to share those with others. So if you would, in the question box, enter what you think is important for your specific team. So one team has entered the coordination of the SBT with the SAT, meaning that, of course, the nurse needs to coordinate when the medications are shut off, whether it's analgesia alone or analgesia and sedative, when those are turned off, and to notify the respiratory care practitioner when it would make sense to come to the room and perform the SBT. Another person has added that the coordination of early mobility with the team members from physical therapy, respiratory care if the patient's intubated, and RN. So again, that's a really great example of how team members would coordinate. When we talk about team coordination, there is a continuum of team coordination where when you're planning to implement, you have your whole interprofessional team together planning tests of change, creating order sets and protocols and processes, for instance. There's another, then the next part of the continuum is how you coordinate in rounds. And then the part of the continuum at the sharp edge where the patient is when specific team members, like we're hearing here, need to coordinate around a specific activity. Someone else has entered communication. And of course, we all struggle with communication in our everyday practice, whether we're at the bedside, whether we're in meetings, or even when we're presenting in webinars like this one. Communication is usually what is shown as where errors occur, are usually not that someone did something wrong, but they weren't able to communicate. Someone else has added clear communication. Again, I don't remember the quote exactly, but it says something like the #1 mistake about communication is that it has occurred. And so really, really important. Another individual has typed in feedback from frontline staff. I think this is extremely important, particularly as you're doing tests of change. Because they're small, you may not really involve the vast number of people that really should be giving feedback, which is why when you do your test of change and cycle through, it's important to do a small one and then expand like a pebble in water to include different people so that you're getting a wide range of feedback from folks doing the work. And again, someone else added feedback from folks actually doing the work. Really important, and important to include all disciplines. Our interprofessional team is comprised of about 6 folks, but we saw in our model that there are many, many others, and there may be really valid and important contributions that other members, aside from pharmacy, rehab, respiratory care, medicine, and nursing have to make. So really, really important. You see anything else there, Dorothy, that you want to highlight?
Well, I would just say that just reporting out on the target RASS and the CAM-ICU assessment requires a lot of coordination, not just nursing reporting it out, but a lot of coordination for others to really understand what it means and to understand how to act on it and to ask about it when it's not present or when it's not there. So it should never be easy to not talk about those assessments and the results of those, but sometimes without coordination, they can begin to kind of fall by the wayside. We see that.
Right. I would take that one step further and say I have seen rounds where the nurse and the rest of the team reports out on everything, but there's no discussion or there's no plan made to actually improve. So for instance, I hear RN say, the target RASS is -1 to 0. The patient's RASS during the night was -3. It's -2 this morning, and they're CAM-ICU positive. And they go on to the next thing. It's really important to perform those assessments and to report the results. But where the teamwork comes in, the cooperation, coordination, and partnership happen when you discuss why those assessments are not within target and you plan what to do next to improve where the patient is and improve the care plan around reaching your targeted goals.
And one other that has come up is this one around pharmacy's involvement and really understanding target RASS and tracking the use of benzos. I don't know if you want to say more about that.
Yes, a lot of our pharmacy champions in our IPTs have really done several things. Just like respiratory care and physical therapy, they have developed a renewed sense of purpose, both in rounds and in patient care. Many of them take responsibility for the choice of medication and recommendations around how to best reach pain and sedation targets. They remind folks in the team about our new targets of being more of a RASS of 0, and also they do things like track benzodiazepine use and report on how that is diminishing, and also report on patient outcomes. So they really take responsibility for not just recommending, but tracking and reporting use of sedatives in general, benzodiazepine specifically, and also reporting on the increased use of the analgesia first approach of using only an opioid for both its pain relief and also sedation qualities.
I'm just reading more of the great coordination pieces you all have here.
One site entered that you're very good at the entire bundle except the E. And I'll say that that's not really unusual. Most sites that we work with, including our own, are able to really effectively implement most of the bundle elements. But the early mobility is the one that is the most challenging. And we heard one of our teams present on that specifically and tell us why it is so challenging. There's a lot of fear involved, because there's fear on actually the nurses, the staff nurses' part, who's caring for the patient. Physicians often, don't want things dislodged. Family is often fearful. Say, isn't my loved one too sick to move? I mean, they're in intensive care after all. So it does take a lot of explanation, understanding, and evidence to explain to families and patients especially, but also to resistant clinical staff, about the findings when patients are mobilized early, and how it not only improves their outcomes while in the hospital, but almost more importantly, improves their outcomes after they leave. And I think when those, certain facts provided to patients in a very clear and understandable manner, and their families, is provided to them, I think, and then including them in providing the mobility, and then empowering them to ask for mobility when it's not happening, are some really surefire ways to move towards successful implementation of the E element of the bundle.
Yeah, and I would say some of our earlier tests of change examples, showing that first win, that celebrating that first mobilization can really begin to create policies around this that you need as well.
So thank you all for chatting, typing in your ideas in the box, and now we'll move on to our next slide.
So really, this is a reminder that change has an uphill climb, and that you're going to meet resistance, and there's always more to do. Not in a helpless way, but just when you start to feel that urge to quit, or, oh, this is never going to happen, there's too many people involved, and I have to communicate with the world just to make a change, just encourage you to think about that tipping point piece. And if you looked at that work by Malcolm Gladwell, you'll know that there is a point where, surprisingly sometimes, everything just begins to click. And I want to encourage you to keep going to see that happen, to keep partnering with each other to make those decisions collaboratively, to keep really having those tough conversations and using those contrasting statements, and to keep looking at what processes do we need to change and coordinate together as a team to make this change. I think that we have a summary slide next, which is just making sure we reiterate what we really want to provide you, and what we've provided our teams around coaching as an interprofessional team. I start out by reiterating that tests of change and those experiments are really ongoing work, that you don't ever stop trying something, and if you've stopped, you probably need to go back to the list of things that need to be addressed. Address conflicts that arise. Workarounds don't work, so trying to address things directly. Change occurs when teams work together, not when individuals go out and try to do it all by themselves. It's really critical to involve others in your team, and we had to learn this one. We had such great initial teams to do this work on implementation, and really had to learn that their job was to go out and get those additional supporters and people on board, kind of one nurse at a time, one pharmacist at a time, one physician at a time to expand that circle. And then in summary, lastly, is what systems do we need to put in place? Not just what's the one thing we need to celebrate today, or how do we get that one physician on board, or that one patient to speak up, but what systems do we need to put in place to make sure this can be sustainable and ongoing?
Thank you, Dorothy. This completes our presentation of content and sharing with your colleagues. We would like to leave the remainder of the time for your questions. Please type your questions into the same question box that you used for your comments earlier. And while you're doing that, I'm going to actually review some of the additional comments that some of our attendees put into their comments around what needs to happen. I say that the fair majority of them relate to coordination around early mobility, and also gaining a consensus about what the goals for the patient are that day. Sometimes physicians or others will agree that mobility should happen, but the goal is not ambulation. And I think that was a great point that someone put in, that they're okay with the patient dangling or even transferring to the chair, but the goal for E, remember, is to maximize or optimize the patient's mobility. And again, Dr. Engel tells us that we, as care providers, are the ones who most frequently underestimate the patient's ability to move. And that when optimized, patients often surprise us and can do more than they think they can, or than we think they can, and they'll do even more the next day. So I think that's a really good point. And again, that seeing believing principle is really important. So if anyone has any questions, please go ahead and type them in the question box at this time. So Diane and SCCM team, I'll tell you that my question box is very tiny. I can only see one line at a time. So we may want to go back to reading the questions aloud, and then we can respond to them if there are any.
Good idea. Thank you. Thank you, Marianne. I'll be glad to do that for you. I do have a personal question that I would like to ask you. How do you address the resistant staff? And by that I mean when you have a staff member that's been in the organization for a very long time, and that staff member is seen as an informal leader, and so whatever that person does, everybody else is going to follow. So how do you convince that person? Because others will follow whatever that person decides they're going to do.
That's a great question, Diane, and obviously something that teams encounter quite frequently. I think there are 3 levels to helping someone move in that direction. So first of all, when we know we have those folks in our unit, we really try to include them as part of the team to get them involved early so that they feel like they have input and that decisions are not being thrust upon them. Mm-hmm. The second is that we provide them with the same education we provide others, so everyone knows and understands the concepts. We then create a standard of care, whether that's through a policy, a protocol, and we create an expectation that each staff member follows that. We then audit individual performances, both to see whether they're correct and to see if we do have any problem individuals who are simply resistive. At that point, it becomes an administrative issue. If the person has been part of the process, whether they choose to, if they choose to, great. If they don't, then that's on them. If they are given the education, if the expectation is created, if they have been audited and their performance feedback has been provided to them and they continue to not comply, then their behavior needs to be elevated to a manager or director, and it becomes an administrative performance issue that where they are given feedback, they're giving warnings, and perhaps it even is reflected in their performance review. Dorothy?
Yeah, and I would tend to emphasize what Marianne said at the beginning, which is include them, involve them, encourage them to be a leader in this way. Have those peers like yourself, Diane, really use those contrasting statements. If they're not on the team currently, have the team troubleshoot this. Sit around for 20 minutes in a meeting and say, who do we need on board and how are we going to get them and what's the best path to influence. Having a strategy, we talk about this with our teams a lot, having a strategy to get people on board versus just saying, oh, they're resistant, or oh, they're not, they're a leader and they're taking us a different direction, that's how it is. Instead, creating strategies around influencing others, I think, can be really helpful, and avoid that path that has to happen, and Marianne's right, that has to happen sometimes, but isn't necessarily going to get you over that change curve more quickly.
Right. I think this also brings up the complexity of change to some respect, where we're advocating with Dorothy's change curve to not worry so much about the laggards, but to get the early adopters and the innovators in with you and then reach that tipping point. But you brought up a really important concept, which is if this laggard person has the ability to negatively influence the folks who are on the fence, that person can do a lot of damage. And so this is a case where you might need to focus on a laggard because of their ability to influence others. And so it is complex and not always easy, but I think we've outlined some steps that most people take to deal with an individual such as this.
Other questions?
Thank you, Marianne. One more question. One of the teams spoke of celebration, of doing celebrations to when you accomplish. Could you provide us with some ideas of what you might have used in the past to reward teamwork or people following not necessarily the rules, but what they're supposed to do?
Yeah, I would say photos. Start with getting patient permission to take photos. All of our teams have these in their binders at the ready, at their workstations, to get patients' permission to take photos, and family members and staff members. It is something that required a little bit of a hump to get through. How are we going to do this? But once we got those permissions and we keep them on file as we need to and have a really solid process, it made huge changes, because you hear about what happened on that other shift when we mobilized, or I heard about it at the party that something happened, but I didn't see it. I wasn't a part of it. So once you start posting celebration posters or photos, or showing the slideshow of from here to outside on the deck, it changes things and works on, of course, only internal media, but we use it internally a lot for getting other people on board.
We have 25 acute care hospitals, and we have a collaboration site devoted to ICU liberation. And so when teams are able to mobilize patients and they send us pictures where everyone's smiling, we post it on that SharePoint site, and we create this little friendly co-opetition among our sites, and we call out the people's names. So in your unit, for instance, you might take a photo of a patient ambulating, and you may say, look what Angie, Mark, and Dr. Smith did, and call those people out and give them rewards. And then you just create this sense of everyone wanting to be highlighted and having their picture taken and being recognized for their good work. And that really helps with the seeing is believing and the tipping point around mobility in the ICU.
Thank you, Marianne. I do not have any more questions in the question box right now. If you all would like to, you can address some of the other answers that were given to what the people were having problems with. If you just let me know, I'll be glad to do that. Or if you just have some wrap-up words you'd like to say.
Well, I think there's one last slide that has some contact information for us there. So maybe that would be a last thing to say, is that write down our emails. They're more than happy to talk to you further about what we've done, partner with you in this work, as we do with the collaborative.
I would like to personally thank Diane and Vishaka for inviting us to present to all of you. I know that those of you that are in the collaborative do have many, many resources that are available to you as you move your work forward. I would invite those of you outside of the collaborative also to contact us if you would like clarification or you feel like you need some help with either beginning implementation or moving your program forward if you've already started it and feel stalled. So again, our contact information is there on the slide. Thank you very much to SCCM. Thank you to my colleague Dorothy, and thank you for all of you who have attended, particularly for those of you that shared your test of change, both in paper form and with your colleagues on the phone.
Thanks, Diane.
And Marianne, yes, thank you. And I would like to thank Marianne and Dorothy for putting both of these together. They spent a good amount of time doing that and gave us some information that I think is going to be very helpful to our hospital teams as well as those who are not in the collaborative. I also would like to thank the hospital teams for presenting today and for sharing their ideas. And I would really like to thank the others who sent their ideas in. Obviously, we would have liked to have been able to present everyone's, but we weren't able to do that. But we do appreciate the fact that you sent those in, and there were some great ideas within those. So if you would like to claim credit for today's session, you can receive continuing education credit by logging into MySCCM using your customer ID and password. Choose the My Learning tab, scroll down, and click on the link for the event to assess a post-evaluation and claim your credit. If others from your institution participated in this webcast but were not registered, please have them send an email to support@sccm.org with their name, email address, institution, and phone number. Once this information is received, they can be registered and can log in to claim their credit. This concludes our webinar, and I'd like to thank everyone for attending. Thank you.